Hi, and welcome to this webinar from EXI, Exercise Intelligence, where we'll be talking about integrating personalised physical activity programmes into medication and surgical treatments for obesity. I'm Dr. Lou Atkinson. I'm the Head of Research at EXI, and I'm also a Visiting Research Fellow at Aston University and the University of Warwick Medical School in the UK. So setting the scene by what do we mean by obesity? Well, obesity is typically classified through body mass index, which is the ratio of an adult's weight to height. And although BMI has some flaws as a measurement of obesity, we do have really great data that demonstrates a clear link between body mass index and increasing health risks or poorer health outcomes as someone moves through those higher BMI categories. And currently within the USA, we have around 42% of adults who are living with obesity. So 2/5 of the population are living with this chronic condition. And because of that, the direct healthcare costs for supporting individuals with obesity is estimated to be $170 billion per year in the USA. We also know that obesity contributes to health inequalities because it disproportionately affects people from different backgrounds and communities. For example, individuals from Black, Indigenous and Hispanic backgrounds all have higher rates of obesity. People with lower education levels, those living on lower incomes, and people living in rural areas are also more likely to be living with obesity. So we see the prevalence of the issue in the USA, and the trend is increasing for higher levels of obesity across the world. If we think about how physical activity and obesity are related, what we know from really good research with individuals who live with obesity is that they often face significant barriers to engaging in regular physical activity. And these include having multiple comorbidities, so living with additional chronic conditions, whether that's diabetes, cardiovascular disease, COPD, and a range of other conditions. But barriers also can include low mood. So typically people living with obesity are more likely to experience poor mental health. Also, we know that they're often experiencing pain and fatigue and limitations in their mobility due to that extra weight. And those things are decreasing their motivation for and their capability to engage in regular physical activity. Individuals with obesity often face significant weight stigma as well, which contributes to low mood and other poor mental health outcomes. But also it means that those individuals generally feel less comfortable and less welcome in traditional fitness or exercise spaces. And overall, all of these things lead to low self-efficacy for physical activity, typically in those individuals living with obesity. And this may partially explain why we clearly see a negative linear relationship between body mass index and rates of physical activity. So as an individual's BMI increases, their physical activity typically decreases. And healthcare professionals are very motivated and very keen to support individuals living with obesity to get physically active, but they also face significant barriers in achieving this. So, for example, they often have doubts about whether the counselling they give around physical activity will be effective, and generally feel quite uncomfortable about providing detailed advice about physical activity. Given the significant barriers that people with obesity are facing, they really do need quite specific and detailed information on how to get active safely and effectively. Healthcare professionals also face significant barriers in a lot of their work, and that's no different for physical activity counselling. So they cite barriers such as not having enough time, not having enough or the right training, and of course it often comes down to reimbursement. So if the healthcare professional isn't going to be reimbursed for providing physical activity counselling, it's very difficult for them to fit that into their practice. So what treatments are available for individuals who have obesity? And particularly in this session, we're going to be focusing on those who have severe obesity. So we're looking at those higher BMI categories, potentially 35, 40 plus, who may have tried some of the less intensive treatments and therapies available for obesity, and they haven't unfortunately worked. So when we're dealing with those more complex individuals where obesity is becoming a very serious issue, there's four main treatment pathways that are typically advised. First of all, we have multi-component education and behaviour change programmes. These typically involve multiple consultations and a fairly long-term programme, meeting with a multidisciplinary team, which will include professionals such as dietitians, nutritionists, psychologists, as well as physical activity counsellors or therapists. And bringing all of those elements together, using behavioural science, we hope that we can change an individual's cognitions around their weight-related behaviours and hopefully lead to long-term behaviour change. Another option that can be used in the relatively short term, typically somewhere between 8 and 12 weeks, is for that individual to engage in a very low-calorie diet. So either just restricting calories down to around 500 or 800 calories a day for a short period of time, or using meal replacements like shakes and soups. And these can be effective because they can help to break unhealthy or disordered relationships with food, and they are also often used to produce rapid weight loss, perhaps to prepare for a medical procedure, but they're not a long-term solution. Then we can go into the surgical pathway. So bariatric surgery typically involves either restricting the capacity of the stomach or actually removing a large portion of the stomach in order to reduce the amount of food that an individual can comfortably consume at once. And finally, and probably top of everybody's awareness currently, is medication. So we have a new breed of anti-obesity medication called GLP-1 agonists. And these have been shown in very recent clinical trials to be highly effective. So all of these programs we know can be effective, but not all the programs work for everybody. So often it's about finding the right program that fits with the right individual, that matches with what's caused their obesity in the first place, as well as what works for them as an intervention. And so we know that the greatest weight loss that we will typically see is with our surgical and medical pathways. Bariatric surgery has been practiced for a long time, but like any surgical procedure, it has its risks. So the new breed of anti-obesity medication is seen really as a game changer. Although it's not without side effects, it doesn't carry the same risk as bariatric surgery, but we're seeing the same levels of weight loss. Now, because medication has been in the news recently and is often flagged up for the significant cost, we're aware that in healthcare systems around the world, in 2024, there are a lot of decisions yet to be made about who will be eligible for this medication, how long they'll be able to take it for, and other cost-related decisions. So it's worth quickly exploring the sort of cost benefit of these new anti-obesity medications. So this was a study conducted by Kim and colleagues in 2023, where they broke down the economic burden of various conditions and various behaviours, and they then broke down the potential for annual cost savings if treated medically. And you can see from that top line here that when we compare obesity to conditions like fibromyalgia and migraine, or to behaviours like smoking, the economic burden of obesity is by far the highest. So almost double what we would see for the cost of smoking, which we know is a huge economic burden of ill health. And what you'll also see are the comorbidities listed there. So for fibromyalgia, typically 2 comorbidities. When we get to obesity, 17 potential comorbidities that these individuals are experiencing, and this contributes to this increased cost. And then we can see clearly that the cost savings of medication for each of these conditions or behaviours with anti-obesity medication, the cost saving is the highest again. So although the cost of the treatment is higher, the economic benefit is potentially significant, with an estimated cost saving per person per year through anti-obesity medication in the region of $2,500. This is another study back from 2015, actually, which gives us these really nice detailed tables looking at how the cost savings accelerate depending on the individual's starting BMI and then how much weight they lose. So how far they can reduce their BMI with treatment. And what we see is this clear relationship that if someone starts higher up in the BMI categories and loses more weight, we get vastly increased cost savings. But if we look at perhaps a more conservative estimate, so I've picked out some of these numbers here. So for example, someone who starts treatment with a BMI of 30, so just tipping into the obesity category, and they lose 5% of their body mass index, cost savings would be $259 per year if they didn't have diabetes when they started treatment. But you can see significantly higher cost savings if they were diabetic when they started treatment. And then when we go up through those categories, you can see how the cost savings start to increase. And then if we have someone with very severe obesity, a BMI of 40, cost savings without diabetes of $643 a year, and with diabetes of over $2,000 a year. So really significant cost savings that can be made year on year following treatment for obesity. So how does physical activity fit into either medical treatment or surgical treatment for obesity? Well, we have a growing body of research that's helping us to understand this relationship. So it's important to note that GLP-1 agonist drugs, so the most recently tested and approved drugs for obesity and diabetes that are GLP-1 agonists, are semaglutide and tirzepatide. These have been shown to be really effective, both in controlling diabetes and, of course, for reducing body weight. And we're typically seeing within these clinical trials, after treatment of usually around about 1 year, a weight loss of at least on average around 15%, which is highly clinically significant. We know that will produce really significant health benefits for those individuals. And now we're starting to see, as the drugs are developed further, weight loss in the region potentially of around 20% or more. But within all of these trials, and now that these drugs are approved for use in the general population, the condition is that they should only be given if the individual is also given advice to reduce their calorie intake and to undertake 150 minutes of at least moderate intensity physical activity per week. So this was the protocol followed in the trials, and this is now the prescribing conditions for any of these drugs when prescribed for obesity or diabetes. Unfortunately, there's almost no data on whether participants in these clinical trials actually changed either their dietary or their physical activity behaviour. And overall on physical activity, we have extremely limited objective data from any of these trials on physical activity, physical function, or fitness outcomes. However, there are a few studies that have given us an insight into how exercise and physical activity might contribute to the outcomes from these drugs. So a 4-arm study of liraglutide, which was an earlier GLP-1 agonist, looked at the combination of the drug with structured exercise in a 4-arm study. And what they found was that participants who undertook either just the structured exercise and had the placebo drug, or undertook the structured exercise and had the liraglutide, these two groups were more successful in long-term weight maintenance than either the control group, who effectively had neither intervention, or the liraglutide only group. And this suggests that exercise can be used to accelerate weight loss outcomes. And this is supported as well in the surgical pathway, where we actually have fairly significant evidence which shows that increasing physical activity both before and after the surgery are both associated with better outcomes. And those improved outcomes include cardiorespiratory fitness, shorter hospital stay, which of course contributes to lower costs, and greater weight loss overall. What's also important to note is that in both surgical patients and those using the anti-obesity medication, we would typically expect to see some significant lean body mass loss. And that could be in the region of 20 up to 50% of their lean body mass loss during the treatment period. Now, we don't know for sure in most cases how much of that comes from lean muscle mass, which is the really important element here, because we know that lean muscle is incredibly important for future health. But typically, exercise will, of course, preserve and increase lean muscle mass. And so there's an indication here that we could perhaps limit loss of lean muscle tissue during treatment by adding exercise or physical activity. And then final point I want to make is that there's really good evidence to support the benefits of physical activity for individuals with obesity, regardless of any weight loss. So Pajitnik and colleagues did a fantastic systematic review looking at these outcomes and concluded there were significant benefits, positive changes at the cellular level, in metabolic function, and for cardiovascular outcomes, and not to mention the psychosocial improvements that individuals experience in terms of increased confidence. We really believe that integrating a physical activity behavior change intervention before treatment, during treatment, and after treatment has the potential for huge benefits. And so if we break that treatment pathway down into those 3 phases, how and why should we integrate physical activity? Well, in phase 1, prior to any treatment, behavior change can be really beneficial. As we've seen from the evidence, we know that prior to surgery, it can help improve someone's outcomes from the surgery, both in terms of long-term weight loss, but also just how they cope with the surgery. And high body mass index does increase the risks of any surgical procedure. So engaging in physical activity before surgery has the potential to increase fitness and also potentially start some weight loss, which will improve their outcomes during surgery. We've also seen some clinical trials of anti-obesity medication where individuals have had a lead-in period where they have engaged in some behavior change in order to induce around 5% weight loss, and only those individuals who achieved that went on to be randomized into the trial of the drug. And so we see that that can be a really fruitful starting point before treatment. And when we start to think about things like eligibility and the costs of these treatments, those tricky decisions do have to be made about who will be eligible for the treatment to be funded. And one of the key ways that we can help to make that decision is by identifying those people who have the motivation and the capability at that time to make the behavior change they will need to make in the long term in order to make the most of these treatments. So we can use that phase 1 initial behavior change intervention to identify who is able currently to stick to the program and have that potential for long-term successful outcomes. Phase 2, during the intervention. Now, of course, with surgery, there will have to be a recovery period, but we know that the sooner someone gets moving after surgery, typically they will recover more quickly. With the anti-obesity medications, these are typically prescribed over a fairly long-term period. So there's a significant opportunity again here to start to build that long-term habit for a physically active future. And we know that incorporating physical activity during that intervention period, as we saw on the previous slide, is likely to increase the overall weight loss during the period and long-term weight loss maintenance as well. And then finally, in post-treatment, so following full recovery from surgery or after the drugs have been de-prescribed, long-term behavior change is hugely important in order to sustain weight loss. And evidence typically shows that while diet and physical activity behavior change are both important for weight loss, physical activity is typically the most important behavior for maintaining the weight that has been lost. So what we're looking to do is try and help people move on from that treatment if we can into a future where they can maintain the weight that they've lost, they are more physically active and enjoying the benefits of an active lifestyle. So how would we deliver that physical activity intervention? Well, we could use EXI. EXI, as I said, stands for Exercise Intelligence, and it's a digital platform that allows the digital delivery of the ACSM's Exercise is Medicine program. Exercise is Medicine is the leading program for chronic conditions and physical activity. And we take all of the guidelines from the Exercise is Medicine program, as well as guidelines from the WHO and various other health bodies around the world around prescribing physical activity for the treatment and management of long-term conditions. And we've built that into a digital platform. The platform itself is FDA Class 1 approved for obesity as the primary condition. However, we also tailor all of our plans for our individual members for any health conditions that they have. You'll see a list of the most common conditions there on the screen. So the platform itself can deal with those multi-morbidities, those multiple comorbidities that we typically see for individuals living with obesity. And how it works is at the user level, there is a smartphone app. And you'll see typically what it looks like here. Once an individual enters their information, which includes their age, gender, their current physical activity levels, the health conditions they're living with, and any medications they're on that might affect their exercise. And then they're automatically produced, based on those Exercise is Medicine guidelines, a personalised plan, which describes frequency, intensity, and time. And the type of activity that individual does is left up to them, because that's really important for long-term motivation, for someone to be able to find a way to be active that works for them. However, we do offer plenty of support for individuals who want more guidance on how to be active. So we know that somebody, for example, who doesn't have a history with structured exercise, they're just getting started on a physically active lifestyle, are likely to want more detailed guidance. And so we have a range of activities within the smartphone app, both video activities with a coach that they can follow along with, as well as activities that use motion capture to guide them physically through each repetition of the exercise. So it uses a front-facing camera on their phone to monitor them as they perform the exercise, give them visual and audio cues. And again, that's really important for building confidence in those individuals who may not have done those types of exercises or activities before, and to encourage them to use good form, good technique, and stay safe. EXI works best when combined with a wearable activity tracker, such as an Apple Watch or a Fitbit. And there's a couple of main reasons why that's really adds to the effectiveness of the platform. First and foremost, it monitors their activity while they're doing it and provides heart rate feedback. So an individual can see that they're working in a heart rate zone that is safe for them, but also that's going to be effective. And secondly, by using the wearable all day long, we're able to monitor that individual 24/7 and provide even more detailed feedback on their activity levels and their health data. And we can gather all of that data and display that to any healthcare or exercise professional who is working directly with that individual on the EXI program. And so, for example, a clinical exercise physiologist or a healthcare professional would be able to view these data at any time, and particularly either before or during perhaps a face-to-face consultation where they're reviewing progress or they're looking at what's the next step in that treatment pathway. And we can see the range of data here that you can get in terms of physical activity, the heart rate during the physical activity, what types of activity they've done, but also a wide range of health data, enabling that healthcare professional to have much more information right at their fingertips and to then have really informed and open conversations with that individual about the next steps. And typically the results that we see across all of our users are really encouraging. So if we look at adherence to the plan, so what percentage of the plan the individual is achieving week on week, for those individuals who stay with the program for at least 12 months, and we do see EXI as a long-term program that someone can stick with for a long term in order to build that physical activity habit and continue to get positive feedback and encouragement. And typically at 12 months, adherence is around 70%. So individuals overall are achieving 70% of the plan we've given them. And that's really, really positive for this population who typically are dealing with multiple chronic conditions, lots of barriers, and are much less likely to have been physically active before they started with the EXI program. Interestingly, we typically see at least around 25% of our users at 12 months are achieving 100% of their plan as well. And what that equates to is a gradual increase in overall activity minutes per week. So all of the plans will progress at a safe and effective level for those individuals, bringing them to 150 minutes of at least moderate activity a week, if that's open to them based on their health. And when we look at how the behavior change happens for different starting levels of physical activity within our users, what we typically see is the greatest magnitude of change comes in those users who start at the lowest level of physical activity. And overall, there are a large number of systematic reviews and meta-analyses now that demonstrate that the biggest health benefits from physical activity are gained in exactly this population. So those individuals who are really, really inactive, if we can move the needle just slightly and help them to become a little bit more active, the health gains for them are much higher than taking someone who's quite active and making them really active. And so in our bottom quartile, our bottom 25% in terms of baseline physical activity, which we take historically from their devices, so we have a real genuine baseline, we see typically around 600% increase in activity minutes, both in the short term and then sustained in the long term. And that also seems to translate into some really positive health benefits. So when we look at blood pressure, for example, we've seen over a 5% decrease in systolic blood pressure. And we've also seen up to almost around 6% decrease in waist circumference across our entire user base. And those data are super important when it comes to understanding the return on investment of an intervention like EXI. Delivering a physical activity intervention, there'll be a selection of data that are used to judge whether the outcomes are worth the investment. But because this is a digital intervention, we actually can collect a huge range of data points, all of which can contribute to that understanding and evaluation. And you see typically the user data that we're able to record and track and trend using that smartphone app. So again, for somebody looking at this at a program level and understanding the impact of the program and comparing that to the cost, using our secure data insights portal, they can see that at an aggregate level. And as we've seen from some of the data I've previously presented, this gives a potential return on investment of around $2,000 per person per annum for those individuals living with a higher level of obesity and additional conditions such as diabetes. There's also, of course, a lot more to the platform that I won't have time to go into, but just to appreciate that we use lots of different behavioural change techniques in order to continue to engage, educate and support all of our users, including regular emails in the first 2 weeks to ensure someone is able to get the most out of the platform, really understands how to use it, really knows what the plan is all about, and encourages them to get involved, knowing what the benefits of that are going to be. We've also built in a wide range of reward structures within the platform. Some of these are what we would determine as social rewards, so badges and the positive encouragement of achieving their goals. But we can also implement more financial based rewards. So for example, we've seen in some of our pilot studies that having the wearable as the first reward, so getting the wearable at the start of the program, can be a significant motivator for a lot of individuals who wouldn't otherwise have engaged in a physical activity program. And then we also can build in regular financial rewards for achievement of those physical activity goals within the personalized plan. And that's really important because the rewards then are linked to that individual. It's not a one size fits all target. They're only being asked to do the amount of physical activity that's right for them in order to earn those rewards. And so when we look at the results that we have for our users who are living with obesity, we pulled out the data for any individual who started the EXI program with a BMI of 30 or more and used repeated measures and overs to look at the changes that those individuals had made through using the EXI program. So these are people living with really significant challenges. The majority of these users had at least one comorbidity, if not many more. And yet we will still see a short-term increase in activity minutes of 132 minutes. So a 50% increase at 6 weeks. And although that was a little bit less at 12 weeks, we're still seeing a sustained behaviour change, a sustained increase of a third. So these individuals are a third more active after 12 weeks of the EXI program. We also saw increases in daily steps, but unfortunately we know that step count is a little bit less accurate than activity minutes, which are typically recorded through a wearable device. When it comes to health outcomes, these are also very positive. So we've seen a decrease in weight of around 4.3 kilos, 9.4 pounds over 12 weeks. That's 4%, and 5% is really what we would look for as a clinically significant result. So approaching that, and at 16 weeks we were really pretty much there at 5%. So if the individual can stick with the program for at least 4 months, they're likely to achieve a clinically significant weight loss. And we also saw some significant decreases in both systolic and diastolic blood pressure. So indications that the physical activity these individuals are doing is having a positive benefit on their cardiovascular health. And really important for us as well is the feedback that we've had from healthcare professionals who are working within these medicated obesity programs or surgical obesity programs. And you'll see here the range of feedback that we have received from the benefits of having the secure data portal in order to really reinforce the behavior change that the patients are making, really support and reward that. As well as having this single tangible resource, as one professional told us, for the patients who have physical activity as a goal. It means that can be delivered to them regardless of whether they are remote or whether they are face-to-face, and it's tailored to what those individuals' specific needs are. And then finally, making that point again around costs, that those individuals using EXI prior to being recommended for further treatment, it really provides a better case for that individual going forward for treatments such as surgery, because as this professional says, it shows they're committed to making the changes and that they will be more physically able to cope with the surgery. So I hope that's given you some food for thought in terms of how physical activity could and perhaps should be integrated into both medical and surgical pathways for obesity treatment. I'll leave the references on the screen for a moment for anyone who wants to check out any of the literature that I've cited in this talk. And of course, if you want to know more, if you want to talk about what the possibilities are, please do get in touch. You can scan the QR code, you can reach out to me directly on email, and you can also check out our website.